Good evening, my friend and colleagues from Asian Oceania region, and also good morning, my friend from North America. My name is Nushrin Tanya Supercall, one of the AsiaSafer. So today I want to welcome everyone back to the lecture series on the AsiaSafe webinar on the Enhancing Optimization Strategy in Radiological Practice series. And today, this is the fourth. This is episode 4 that we are going to talk about the DR and CR technology back to basic because since right now we're still doing a lot of DR and CR study. How can we make the image quality optimal and how can we get the correct diagnosis with less radiation dose to the patient? And as usual, we have Dr. Jamari Sopon, who is a president of the AOSR, joining us today, and she will give the opening speech on this session.
Thank you. Good evening, good morning, everyone. Welcome to the fourth session of the AsiaSafe webinar series 2025. Today is Back to Basics, Achieving Quality and Efficiency in DR and CR. I'm Dr. Jamari Sopon, President of AOSR, and I'm delighted you are all here. Tonight, we will focus on practical way to balance radiation dose and image quality, key to safe, effective, and patient-centered radiology. We joined by two outstanding experts, Professor Samuel Brady from Cincinnati Children's Hospital, USA, and Dr. Amel Antony from the Lisie Institute in Kerela, India. Their insights will help us apply global standards in both advanced and resource-limited settings. Thanks for being part of this learning journey. Let's get started. Back to you, Dr. Supakun. Thank you.
Thank you so much, Dr. Jamari, for the welcoming speech. So let me share my screen. So there is a couple things here. So this is the lecture series. This is episode 4 that we are going to talk about the DR and CR. And let me introduce Dr. Samuel Brady, who is also the key speaker on this webinar series. He is the chief medical physicist from Cincinnati Children's Hospital, professor at the University of Cincinnati School of Medicine, and fellows of the American Association of Physicists in Medicine. He has an international experience working with the IAEA, IAOC from Thailand, and also part of the International Electronic Committee that developed technical standards for the safe performance of the CT medical equipment around the world. He is also the vice chair of the Imagently Alliance, chair of the ABR Radiologist Examination Development of Physics Qualifying Core Exam, also chair of the AAPM Annual Meeting Education Program Working Group, and also the member of the AAPM Ad Hoc Committee on the Artificial Intelligence Bootcamp. And our second speaker is Dr. Amel Antony, who is a senior consultant radiologist and head at the Lisie Institution of Radiology Research and Imaging Science at Kochi, India. He has experience more than 30 years and also the postgrad teacher and examiner. He also past National Vice President of Indian Radiological and Imaging Association and also former member of the Governing Council of Indian College of Radiology and Imaging. So before we're gonna start on the lectures from Professor Bailey, when you log on, so I think right now the audience, everyone is using the Vidocto platform. So when you click on the Vidocto platform, to be able to have an interactive response, send the questions to the speaker, you need to put your name and join audience. So by that way, you can type your questions or the communication or any message that you want me to talk to the speaker today. So please log on, put your name on. It can be the ABCD 1 2 3 4. It does not need to be your actual name if you does not want people to know that you are watching on this webinar, or it can be your actual name. And then we need the feedback. We really need the feedback on how we're doing or what topic that can help the audience in this region. So please scan this QR code. If you watch this like a webinar on the computer, you can use your cell phone to scan the QR code. And we also send the link on the chat box when you log on to the Vidocto platform. So by this way, you can give us a feedback on what we can do better or what topic that can help this region. Okay, thank you so much. So I'm gonna turn like this stage to Dr. Samuel Brady on his talk. Thank you. Welcome.
Thank you. Thank you for that introduction. I'm going to share my screen real quick.
Mhm.
Okay. Well, I appreciate the invitation to be back and to talk. And we're going to talk today about DR and CR. And I want to go back to the basics. And I'm going to talk more from the physics perspective and how setting up select techniques and patient positioning, how those two very simple things can actually make a very big difference in the image quality and patient dose that they receive during a normal radiographic procedure. Oh, here we go. There we go. So why back to the basics? We have seen an amazing change and explosion really in technology for DR and CR imaging, but you cannot get away from the fundamentals. Technology does not replace fundamental technique selection and patient setup. I'm going to break my talk into 3 areas. And first, I'm going to talk about the fundamentals of how image quality and patient dose is affected by various different technique settings, setting up the patient, distancing, SID, patient positioning, and collimation. So probably one of the most important factors that you will adjust in X-ray is the tube potential, or KV value. A high KV value has a more penetrating X-ray beam and therefore will pass through both bone and soft tissue fairly equally, which leads to lower image contrast. Conversely, lower KV leads to less penetration, more absorption, especially in bony anatomy, leading to a better tissue contrast. And we see this all the time when we're imaging, for example, a normal hand radiograph. At low KV values, you see a stronger difference in contrast between the bone and the soft tissue. Whereas at higher KV, almost equal penetration leads to poor contrast differentiation. Now we can use this understanding to our advantage. When we do a normal chest radiograph, generally we are imaging at high KV because we want to penetrate and make the ribs fairly transparent so that we can see the underlying lung parenchyma. Whereas if we want to see the ribs, we're going to use a lower KV so that we can see the bony anatomy. So understanding the effects of low KV and high KV, how that affects image quality, it's a physics concept, but it really does affect the overall quality of the image on the back end. Now, small changes in KV lead to very large changes in radiation dose. And this is because, as you may recall from way back in school, when we change MA, or the radiation output, it changes linearly, as you see here with this curve B. But when we change KV, it changes quadratically. So it changes quicker as a function of KV. So let me give you an example. If we want to change the KV by 40 value points, so if we go from 120 kV to an 80 kV exposure, because it's quadratic, we have to square that ratio, and we get a 56% dose reduction. But for MA, if we change it from 120 MA to 80 MA, we only get a 33% dose reduction. And that's why when we change MA, it does affect dose and noise, but KV changes it quicker, makes a more strong change. And as we demonstrated in the previous slide, it also affects the image contrast in the image. Because of this, we have that 15% rule that most of you were probably taught in school. Because KV behaves quadratically and MA behaves linearly, if we increase KV by 15%, we can decrease MA by 50% and get the same image quality. Conversely, if we decrease KV by 15%, so we can see more bony anatomy, we need to increase the MA by 50% so it's not too noisy in the image. So you get good contrast because of KV selection, and the noise isn't too bad. And so MA, as you know, increases the number of X-rays in the image. So does KV. KV increases the number of X-rays in the image, but it also changes their energy. And because the energy changes, that's what affects image contrast. So now talking a little bit more specifically about the tube current time product, or MAS. So MAS is a way to determine how many or the number of X-rays, photons, reach the detector. High MAS obviously leads to a less noisy image, but it leads to higher patient dose. Lower MAS leads to a noisier image and a lower dose, but it can be compromising. Excuse me. It can compromise the diagnostic quality of the image. In modern X-ray imaging, we use automatic exposure controls, or the AEC system, to select the proper MAS every time we image a patient. And so you've seen this all the time when you look at the chest bucky, or even in the table, you have these ion chambers that are placed behind the cover, and they measure how much radiation is passing through the patient during the exposure. And they will turn off when they receive enough radiation to the detector. And this ensures that we are consistent and we have reproducible exposure to the detector, no matter the size or thickness of the patient, no matter the KV that we select, low or high, and no matter the skill level of the operator. And using AEC is a great way to try to keep consistent image quality across the entire across your entire patient population. The caveat to using AEC is when we're imaging pediatrics or little kids, almost always they are too small to cover, their anatomy is too small to cover the proper AEC cell. So if you're doing a chest radiograph, this young lady here, these chambers are too big for her lung field and would not produce a good image. And so we have to be mindful of the size of the patient, the anatomy that we're imaging, if we're going to use AEC. And here is an example of when setting up the patient for AEC can lead to poor image quality. In a typical lateral chest radiograph, you would normally select the center cell to operate and choose the right MAS for the exposure. But in this case, the technologist accidentally left the left and right cells selected, and when they acquired the image, this left cell, which was directly over the detector, it immediately caused the system to shut off because the detector measured a high level of radiation. So it thought it was a very, very small patient. In reality, it wasn't. It was just direct exposure to the detector, which led to an extremely underexposed radiograph, which required a repeat imaging process. So setup is important now that we transition from selecting our KV and MAS. Setup and proper selection of the AEC operating system is very important. When we come to talk a little bit more about the exposure uniformity, we need to talk about the Hill effect. The Hill effect is something you probably studied once again in school. It's the phenomenon that occurs inside the X-ray tube. The electrons, when you pull that trigger, the electrons are released from the cathode and they come and interact with the anode or the target. They undergo Bremsstrahlung radiative interaction, and that interaction is what creates these X-rays. But because some X-rays will pass through more material, anode material, they will have the tendency to get somewhat more absorbed on the anode side than the cathode side. And this leads to what we call the heel effect. In other words, the intensity of the X-ray beam is lower on the anode side of the X-ray tube than the cathode side. And that's okay. We can use this principle when we set up our patients. Here you can see on the left, I made a plot of the exposure. So I took my chamber and I made measurements from the anode side all the way down to the cathode side, and then I normalized it to the center. And you can see at the anode side of the X-ray tube, there's almost a 60% reduction in X-ray intensity. And that's why when we set up our X-ray tube, we always place the anode side up or over the thinnest part of our body. And so the thicker part of the body will be penetrated fine because we have more X-rays coming from the cathode side. You can kind of see this in this image up here, where more X-rays will pass through the thicker part of our body, less X-rays will pass through at the anode side, but the exposure to the detector will be more uniform. So patient positioning and setting up the tube with respect to the patient size is very important. Now let's talk a little about spatial resolution in the X-ray image. There are two factors that affect resolution: focal spot size and geometric magnification. We've all been taught that we want to use the smallest focal spot size possible because that allows us to be able to see the smallest objects in the X-ray image, the smallest objects that are closest together. And so that's the best way to resolve small objects. Now, the small focal spot is good because when we image across the edge of an object, it creates a small shadow, which is called a penumbra. And that small shadow will soften or blur the edge of an object. But because it's a small focal spot, the object blurring is minimal. Whereas if we use a large focal spot, we get a larger shadow or penumbral effect, which leads to less sharp objects in the image. And that is why spatial resolution is degraded when we choose the larger focal spot size. Ideally, we would only use a small focal spot for all imaging procedures, but with the small focal spot, we are MA limited, which is to say that if we can only turn the MA so high before it overheats the tube and can actually cause the tube to break. And because of that, we usually only use small focal spots when we're doing small parts, maybe MSK, hand, wrist, ankle, foot, and small people. And so we have to be cognitive to use the small focal spot as often as we can to keep the image as sharp and crisp, with the understanding that as we get larger, it's a trade-off between resolution and penetrating the patient. The next effect that affects spatial resolution is the position of the patient with respect to the detector. So in this case, we will see blurring as the object that we're looking at gets farther away from the detector. The farther it is away from the detector, the more you get that penumbral shadow effect. And so this is an effect that deals with magnification. Magnification looks at the distance from the focal spot to the detector, the source to image distance, in this example, A plus B, and the distance from the object to the detector, which is usually the thickness of the patient. And that is the source to, B. And I'm sorry, I misspoke. The source to image distance divided by the source to object distance, which is simply A. My apologies, I misspoke there. So source to image distance, SID, over the source to object distance, which is SOD. And that is how we calculate magnification. And so the key take home for this is when we can do that, when possible, we want to keep the anatomy as close to the detector as possible to get the best resolution and sharpest, crispest image to minimize the blur in the image. Now, when we're looking at really small structures, or we're looking for, say, small fractures or fine fractures, then it's great to put the anatomy close to the detector. When you have grosser and anatomical findings that you're looking for, maybe you're looking for pneumonia in the lung, so it's very diffuse and big, then you don't necessarily need the anatomy directly on the detector. You can be a little bit further away, such as on the tabletop or on the wall bucky, and then the resolution is not compromised. But when you're looking for small structures, you want to get as close to the detector as possible. And you can see this in this example. The closer the object is to the detector, the smaller the penumbral effect, which is to say the edges are crisper, they're sharper. And so farther away, you get more of a blurring effect, and larger focal spots, you get even more blurry. The next thing to consider when setting up our patients is to deal with scatter in the image. Scatter is created when we deal with the size of the patient, its thickness, and the area of the collimation, the area of the image field of view. So less scatter comes from thinner body parts and smaller field of views. And you can see in this example, I've coned in just to see the spine, but here you can't see it, but this was a very wide collimation. So it's the whole abdomen versus a narrow collimation looking at just the spinal column. And you can see the difference in contrast between the bony and soft tissue because there's less scatter in the narrow collimation compared to the wide collimation. And so the take-home message for here is tight collimation reduces scatter and gives us good image quality. Collimation also directly affects the quality of the reconstruction of the image. And that's because when you acquire the image, the detector reads out the signal, and what it does is the first thing, it creates a histogram of all of the exposure pixels. And so, and the histogram is unique to the shape or location of the anatomy you're imaging. So a chest radiograph histogram looks uniquely different than, say, a knee radiograph, a knee x-ray histogram. And because they're uniquely different, the reconstruction algorithm, is looking at the shape of the histogram, and it uses that shape to reconstruct the image. And that's because each of those peaks and valleys in the histogram represent different aspects of the anatomy that you just acquired an image of. And so when we collimate properly, the system, here you can see this lateral skull with the pseudo coloring on it. You can see that it's been collimated really tightly. And what the system will immediately do is it will remove that background image, all those white pixels will disappear. But when it does that, it reduces those pixels in the histogram. And by doing so, when the reconstruction algorithm then maps the image, the grayscale to this for this lateral skull, it only has to do so for these pixels and not these pixels. And see, reconstructing an image with these pixels versus these pixels will change the look of the image. So collimation is absolutely important when we get selecting the right reconstruction algorithm on the back end before the go to the radiologist. Substitute. In other words, and then after the fact, you use the shutters to cone in, so the radiologist only sees the lateral skull, but the reality is the whole image, the whole part of the body was exposed. The problem with that is that this histogram does not change, and so the image quality is compromised. So I keep saying that we map the grayscale in the image based on the shape of the histogram. And that's because we go through and we look at all of the various different pixel values and we map it to the blacks and the whites and the grayscale. And that's what gives you the quintessential look of a radiograph image. If you do not use the right collimation and select the wrong reconstruction algorithm, the contrast in the image will be drastically different. And this is an example here where I demonstrate using the proper chest reconstruction algorithm versus using an abdomen chest chest algorithm, reconstruction algorithm. You can see how it drastically changes the view or the contrast in the image. So collimation actually directly impacts image quality. Yes, because of scatter, but mostly because it changes the shape of the histogram, which will confuse the algorithm on the back end. So, and also the next thing, it's probably pretty obvious, is collimation also directly affects patient dose. So large areas where you fully open it up and now you're exposing more of the abdomen, the neck, and the thyroid in this case, the arms, that's just more radiation exposure to the patient, but it doesn't change what the radiologist needs to see. Whereas a good, properly collimated example here reduces the patient dose. And also, collimation is one of the best ways to keep radiation exposure low to the fetus when we need to image a pregnant patient. We can image pregnant patients in radiography because the radiation exposure is very, very low. But by keeping good, proper collimation, so there's a bigger distance between the edge of the X-ray field and the fetus, you can keep the dose incredibly low. In fact, a typical example of this is the dose to the fetus is less than about 10 microsieverts, which is on order of 1 day's worth of natural background radiation. So you're not increasing the risk as long as you keep that collimation tight. So moving on now to the next the next section is the quality control based on a couple of other things we can do that doesn't necessarily relate to patient setup. The first is keeping our equipment properly calibrated. These digital detectors, mostly the DR systems, they require calibration every day and periodically throughout the month or quarter. And they do that so that when you look at a raw image, if you were to go in and take an image with no patient on the table, there's going to be blemishes. There's going to be areas where the pixels they're just dead. There's no signal. And so by going through these calibration process, we can actually clean it up so that when we do have a patient, we can expose them using a nice, clean, uniform image. And so going through and calibrating the system properly on the normal schedule, some vendors will have you do it, say, monthly, others may do it quarterly. But doing this will help you keep these blemishes out of the image. And so one example is oftentimes when we image, say, someone with a prosthetic, or we image a really big patient, and then the next patient that walks through the door is a really small patient, we can get this latent ghosting of the previous image. And that's because the system hasn't calibrated before the next patient walks in. And so if you see these ghosting effects, you can usually just immediately stop imaging patients, recalibrate the detector, and then these will go away. Here's another example of where when the technologists skipped doing their quarterly, at our place, the quarterly calibrations, these blemishes in the detector, they now appear in the patient exam. So it's simple to do calibrations, but it's actually very powerful to make sure we have a nice, clean, good detector ready to image our patients. And I know sometimes we get busy as we're going from patient to patient to patient every day, every week, every month, but it's important to take 10 minutes and do a calibration when it's due. All right, so how do we know when our exposure levels are appropriate and when are we over or underexposing our patients? With modern digital radiography and computed radiography, CR, we have something called the exposure index. And it could be called EI, it could be EIX if it's Siemens, it could be the S value if you're in a different vendor. They have different names, but they do the same thing. They measure the average dose to the detector through the anatomy of interest. So if we're doing, say, this C-spine imaging, we want to make sure we get the right dose through the C-spine so the image quality will be appropriate for the radiologist to make their reading. We don't care as much about the dose through, say, the soft tissue or the shoulder or the skull. And so the EI value measures the dose through these areas of interest. EI is not a patient dose metric. It does not tell you how much radiation the patient got. What it's telling you is there enough signal to noise ratio, enough image quality in the image based on the exposure that you performed. That means every different procedure, C-spine, chest radiograph, abdomen, hand, everything will have its unique target EI value. And that can be difficult to memorize all of those values to know if your exposure for this one patient was appropriate. And because of that, they've come up with something called the deviation index. The deviation index, or DI for short, is a simple mathematical equation that takes the EI value measured for the patient you just imaged and divide it by the target value that's programmed into the machine. So you don't have to remember the target values. You don't even have to know if the EI was accurate. All you need to know is if the DI value was appropriate. Because it's a ratio, what we know is that if the DI is 0, that means the exposure you made in that moment is equal to the anticipated target. Therefore, it was perfect. And so DI of 0 represents a good number. As the values change, as they increase, so they're positive values, that means dose goes up. And so if you see a DI of 1, that means you overexposed the detector by 20 to 26%. Or if it goes down, it's a negative, you underexpose the detector by that amount. When you get to really high numbers, plus or minus, say, 10, for example, the image quality is going to start to suffer. In fact, if you get too high, you're going to see something called a burnout effect, which I'll show in the next slide. So just remember, the goal here is when you make an exposure, your DI value should be very close to 0. And if you get there, that means you should have confidence that you put the right amount of radiation dose to the detector to get the right signal to noise ratio. Now, as I mentioned, sometimes we can underexpose and we get a really negative number, like -5, 10. But other times, if we overexpose, we get what's called burnout, where we've saturated the detector. So there is no more signal here. And you can see, obviously, the radiologist technically I window and leveled it really sharply so that you can see the burnout effect. And so when you see a high number, a high DI value, you need to look at the image and make sure the image has all the information necessary for the radiologist. Oftentimes, you need to ask the radiologist, can you look at this image and tell me if it's okay? And if it's not, then you need to reacquire the image to make sure the radiologist has the information necessary for the diagnostic task. So for radiologists, we need to make sure we review these EI or DI values. This is what helps us to make sure the dosing to our patients and our images are consistent over time. Back in the olden days when we had screen film, so film technology, the film itself told us if we were right or wrong. If you underexposed, the image was very white. If you overexposed, it was very dark. It only looked good if you did right. Digital, you can see here, you can actually be pretty low and pretty high dose, and the overall quality generally stays the same. And so for us, we want to make sure that we don't have something called, it must be on my next slide, dose creep, which is to say that, right here, dose creep. I got my slides out of order. That if the images look okay, generally speaking, all the time at a higher dose, then what we do is we have a tendency to just turn up our technique factors. And so radiologists won't call up and say, hey, this is too noisy of an image. And obviously we get in trouble. We see this mostly in portable x-rays because we use fixed techniques, but dose creep can really affect patient doses over an entire population. Now, going back to my previous slide, and this is because when you look at the exposure techniques, you can go as low as 50% too low, and the image will still be okay, right? So you underexpose by about 50%. It's a little noisy, but it's still pretty it's okay. But you have to go over 200% exposure before you start to see burnout effect. So you can see that it's easier to overexpose and not get a bad image than it is to go under. You go just a little bit under, just say 50% under, now it's starting to get too noisy, and the radiologist will usually say something. So dose creep is important, and the radiologist and obviously technologists need to work together to make sure they analyze and look at their values over time. So you look at your chest radiographs, you look at it for a month or a quarter or a year, you see that the values are consistently getting higher, you know that over time, we're starting to turn up the knobs a little too high. And so we can adjust through education and bring those values back. All right, and the last thing I want to talk about briefly is talking about lead aprons. Something of all the things that are changing in radiography, the use of lead aprons is actually one of the areas. Here in the United States, we have largely discontinued using these lead aprons, or at least there is a movement to stop using them. And so why is that? Well, at our hospital, and like a lot of other hospitals, for really well over the last couple of years, we've stopped using primary shielding. In other words, shielding that is directly inside the radiographic field of view. So eyes, breast, and then gonadal shielding. And the main reason for this is because these shields were introduced back in a day when radiography was a really high dose procedure. And when you compare where we were, 50, 60, 70 years ago, today, we're not even a fraction of that dose. We are 10, sometimes 100 times lower in radiation exposure. And so by putting those, we don't necessarily need to place those shields directly over these sensitive organs anymore, because the exposure is so very low that the risk factor is negligible. In one example, in one study, they did a meta-analysis of 18 other studies, and they looked at positioning, and they found that what ended up happening with these primary shields was they were oftentimes mispositioned. 85% of the time they were mispositioned for females, 52% of the time they were mispositioned for men when placing a gonadal shield. So first and foremost, they're not protecting the sensitive organ. But second of all, oftentimes they're going to start covering up important anatomy, and so the radiologist then requires a second acquisition, and therefore you've doubled the patient dose. So mispositioned shields actually do not save, but increase potential risk. We did a study at our institution, and we wanted to know how far the mispositioned shield has to be before there was no dose savings. And as little as 4 to 6 centimeters off its ideal location, you can see that the exposure to the testes and ovaries, basically, there was no dose savings. The value dropped very quickly. In fact, what we did when we did these studies is the majority of the exposure to the ovaries and the testes comes from internal scatter. And so it doesn't matter if there was a shield over top of the ovaries or the gonads or the testes, there's still enough radiation exposure internal to the body that we weren't actually reducing the exposure in a meaningful way. And then finally, our understanding of risk, especially around gonads, has changed over time. There are 3 areas of risk we consider when exposing the gonads: mutagenic effects, in other words, passing a mutation on from mother to progeny, and we found that there are no effects when we looked at the ABOM survivors. Tissue effects or deterministic effects, such as sterility, these exposure values are so high we will never be able to achieve those in X-ray. To do a permanent sterility in men, you need 3 to 6 gray. and we're imaging at maybe 0.5 milligray. So we are so low compared to what would cause a tissue effect. And then cancer risk, these values are incredibly low. So when you look at a 0.1 millisievert exposure, you can see that the risk for cancer induction is 0.0005% for men and 0.0008% for women, just incredibly low. The other thing with these secondary shields, when we're imaging the anatomy, these secondary shields are meant to stop radiation that are outside of the X-ray field. And here I did a simple couple of measurements to demonstrate that when you look at the X-ray field and the light field, they are pretty much equally matched. In other words, you don't get X-rays outside of where you see the light field. In fact, when I made a couple of measurements inside the light field, and then I made a series of measurements outside the light field, here I'm zooming up to that part of the body, part of the graph. You can see that the exposure drops to almost zero. It goes to 0.2% after only 5 centimeters. In other words, just a little bit outside of the light field, there is no radiation. In other words, these secondary shields are not actually stopping any radiation because there is no radiation there. I did a simulation to demonstrate the risk factors by removing the secondary shields that oftentimes we use. And I used a typical PA chest radiograph as an example. Here's my technique factor. And what we did is I looked at the simulation and I found that the doses here, you can see the doses outside of the field of view are pretty much zeros on the superior side and inferior side of the field of view. And then the ones that are proximal to it, such as like the oral cavity here, are a little high, but compared to the actual direct exposures, they're very small. Now, the colon gets a little bit direct exposure, and so does the small intestines. So I actually calculated the risk by not using secondary shielding. And you don't have to understand the equations, but understand that I once again calculated these values were very, very, very low. I would argue that there is no risk from colon cancer because we took the secondary shield away. All right, in summary, dose optimization starts with patient positioning. Good techniques such as collimation and setting the correct KV and MAS if you're using a fixed technique, or positioning properly so the AEC works properly. Patient shielding may or may not be necessary anymore. I think with time you'll see, at least here in the West, we're not using shielding that often anymore. And then the most common issues that I found over the course of my career is dose creep or exposure creep. So using EI and DI to make sure we're not overexposing our population with time, and collimation. Make sure we work with our technologists to set the right collimation so that keeps the scatter down, image quality up, and patient dose low. Thank you.
Thank you so much, Sam, for the excellent lectures and simplify things for us. So before we go to the question and answer session, we are going to have the second speaker, Dr. Amel Antony, to give a talk on the clinical application on the DR and CR. So welcome, Dr. Amel.
Are my slides visible?
I cannot see. You can share your screen now.
Yeah.
And in the meantime, for the people who watch these lectures on the Vidoctor platform, if you have any questions, please feel free to put on the chat box and I can pass along those questions to the speaker. And we're gonna post the link for the evaluation on the chat box too. Yes, we can see it now.
Yeah.
Yep.
So thank you, ASR, especially Dr. Chamri, Dr. Evelyn, for giving me this opportunity today. Good evening and good morning to all the listeners here. And thank you for the kind introduction by Tanya Supuku. And Dr. Nang is also here. Thank you, sir. And before I go into these actual clinical implications of optimization of quality and efficiency in DR and CR, I would like to thank Professor Samuel Brady because he has covered most of the things from the quality side. Now, as radiologists are concerned, we are really bothered about two important things, that is resolution and contrast. Because when we look at CR and DR images, that's what is very important to us. And in addition to this, whether proper radiation protection practice and ALARA principle has been put into effect or not. So spatial resolution and contrast resolution already Professor Samuel Brady has said, but this is very important when we are interpreting our images. He has already gone through all the technical factors which can affect resolution. But I would like to emphasize this again, that spatial resolution, we all know that it's better in film screen radiography. And DR and CR are sort of a compromise between spatial and contrast resolution. In fact, DR and CR came in because of their extremely good contrast resolution, and because of which we have a very high latitude in our exposure factors. All these things have been dealt with. Now, the question here is which we should go for. In fact, when we are going for thinner structures where spatial resolution becomes very important. But when we are looking for multiple areas with multiple densities where contrast resolution becomes much important. So now this is a trade-off where we have to look for example, if we are looking at a fracture in scaphoid, now that is a very small bone where we require greater details. So there our spatial resolution becomes important. But if you are looking at the lung parenchyma and the mediastinum, where our contrast resolution becomes much more important. Now, all these resolution factor, we know that as we have a higher matrix, the resolution increases and improves. And also, that is a comparison where we can see that with mammography, thinner phosphor layers, we have 10 lines per millimeter, while the routine other images, we have 5.5 or 3.5 lines per millimeter. Now, the other important factor which we look for is image enhancement, because brightness is something which is very important. As already pointed out, two dark images will not be able to differentiate between structures which are lying adjacent to each other. Now, brightness has to be controlled. Now, with the present modern day monitors, there is a possibility that brightness can be adjusted at our end itself, but even then the brightness has to be controlled. And contrast enhancement is also possible now, but noise reduction is something which cannot be done at the radiologist end. If there is noise, that means if the exposure factors are not really good enough and the post-processing before it is sent to PACS is not proper, this noise reduction may not happen at all. And edge enhancement is something which we require when we look at thin areas. For example, we want to see a thin pneumothorax, or we want to see a thin pleural effusion. So in such cases, edge enhancement is very important. Now, this is again done at the technologist end after the image has been acquired. Brightness control, I have already talked about. We can see how brightness control can hide structures, or optimum brightness control can give you more details in a chest radiograph. Contrast enhancement, again, in a similar manner, low contrast and high contrast. Again, it is very important depending on the structures which you are trying to image. Noise reduction, again, ideal optimal factors are required so that noise reduction is optimum for the particular part you have x-rayed. Now, already these are there from the physics side. Detective quantum efficiency. Now, this is a parameter that reflects the efficiency of photon detectors and the noise. Now, we all know that it has to be 100%, but at the same time, because of absorption of X-rays, it is less than 100%. So some amount of noise is always there. So the advantage you can see here between film screen, CR and DR. Film screen has got a DQE of only of 25 to 30%, while CR shows improvement, while DR has a DQE of 65%. So that is the reason why we are able to reduce the dose in DR and yet achieve the same sort of contrast and spatial resolution. Now, scintillator thickness, receptor properties, these are all important, and also the modulation transfer function, the information recorded and the information available. Now, normally we should have the highest modulation transfer function possible. So that is again a comparison there between film screen and DR, fluoroscopy, ultrasound, CTMR, and gamma camera, and so on. Now, to summarize, spatial resolution still, as compared to CR and DR, film screen radiography holds an edge, while contrast resolution, CR and DR holds good, and it's far ahead of film screen mammography. So that is, you can see the difference between conventional and digital radiographs there, and you can see the contrast resolution, how it is better with digital radiograph. Now, so that is again tissue equalization. These are all software properties which can be add-ons to your CR and DR, by which you can equalize tissues and you can gain much more information from the X-ray part which you have taken. Now, finally, when you talk about factors contributing to image quality, already Professor Sam has dealt with all this, the patient positioning, the equipment side, the patient condition, what are the clinical indications which are required, and most important, the exposure parameters. Though we have got latitude, still the exposure parameters has to be optimal and ideal for the part which is X-rayed, and the receptor quality, how the quality has to be maintained, and most important, the technical experience and skill of the technologist who's involved. Now, how do we improve efficiency? We have already talked about quality. Now, streamlined workflow. Imagine if it's a busy OP department where you have to X-ray quite a number of patients in a short span of time. Obviously, the choice of equipment should be a DR, because DR is much faster, post-processing is much easier. There is no change of cassette which is required, especially if you're going on taking chest radiographs. You don't have to change anything, just have to acquire images, and somebody else on the other console can keep processing it, and somebody can keep exposing. So increased throughput with streamlined workflow is possible with DR, and to a certain extent with CR, but definitely DR scores over CR. So developing optimized imaging protocols and consistent high quality image acquisition, and also your exposure factors and positioning should be proper, that you can avoid repeat scans. And automated systems where you have automatic data acquisition, which can save time and also can increase throughput. And other areas, already dose creep has already been dealt with, because that's an important area which we should be concerned about. And even more important is effective training. When people move on from plain radiograph to CR and from CR to DR, at every step, our technologists have to be trained thoroughly to understand the difference in the techniques involved and how we can get the optimal image resolution from the exposure you have given. So improving adaptation and efficiency should be the key word, especially when training is given. And proper system management. Now, proper system management implies a robust quality control system. How to monitor and evaluate image quality. Now, this is not something which is done every month or once in 3 months. Now, this is something which should be consciously done at the technology side, and whenever there is in doubt, even the other team members should be involved, like medical physicists and the radiologist. Whenever there is doubt, already as pointed out by Sam, whether the radiograph is appropriate for the sort of clinical data which is required from that particular film or radiograph. And more important, ensuring compliance with regulatory requirements. Now, that means regulatory requirements of the country, and going in for ALARA principle, and rest of all the regulatory requirements which are required for multiple equipments which are used, and promoting efficient and accurate diagnosis. Is the radiograph adequate for the clinical indication for which it has been taken? Now, this is something which the technologist has to be aware. when the exposure has been done and the processed image comes on the screen, he or she should be clear that this is adequate, and when required, immediately the radiologist should be contacted and asked to have a look at the radiograph so that unnecessary repeat radiographs can be avoided. And finally, quality and efficiency. How do we achieve this? Now, this is not something because as in medicine throughout, this is always a teamwork. Now, the team consists of radiologists, medical physicist, technologist, and a biomedical engineer. Now, all these four players are key members of this team. Of course, with technologists having to play the major role, medical physicists looking into the quality part, biomedical engineer looking at the maintenance of the equipments, and radiologists looking at the adequacy of the exposure and the resolution which has been achieved. And above all, and utmost importance has to be given to the patient factors. That means the proper or optimal patient positioning and optimal dose, and avoiding movement artifacts and avoiding unnecessary repeat exposures. So whenever required, for increased workflow, for better throughput, one has to prefer DR, though the DR equipment is costly as compared to a CR. And also maintenance becomes costly for a DR while it is simpler for a CR. In a ICU setting, there is still a role for CR because of the flexibility in positioning patients with CR cassettes, which may not be possible with DR. So with that, CR and DR are good enough. They are definitely better than film screen practice which we had, but for better throughput and reduced radiation dose, definitely DR is the answer. Thank you.
Thank you so much, Dr. Amel Antony, for giving the perspective on the clinical application and suggestion on the how to make the workflow, streamline the workflow. So, let's see. So, I mean, like for the audience who watch the lectures on the VDoctor platform, if you want to ask any questions to the speakers, please feel free to add on the chat box. And there is a couple questions. So first, I have a questions for Sam. So you mentioned about the DI and EI on like the quality exposure things, if it's good or not, right? So for me, as a radiologist, when I read the study, I have no idea how can I look on those numbers. How can you help me? How can I know that like this is good enough or not?
That's a great question. So DI values, ideally you'll choose DI over EI. And you need to work with your PACS team. Oftentimes with your hanging protocol, you can have it so that the DI will appear in one of the corners. So you might see KV, MA, and then the DI value would be listed. In which case, as long as you understand that that value is DI and it says 0 or +5, you would then be able to make that assessment. And then if you start to see over time a higher and higher number, you can maybe make comments. In the moment, when you as a radiologist look, and if it's listed and you see, oh, it's +3, you'd be, okay, I have confidence this is a good image. If it's +10, then you go, okay, I need to look at this image a little closer to make sure there's no burnout, say, in the lungs. Long term, what we need to do, like Dr. Antony mentioned, is we have to look at this in a quality control program. And so now maybe monthly or quarterly, you have your radiologist, your technologist, like the manager of technologists, and maybe a physicist if you have one. Then you can sit down and plot it out. And so now you see 1,000 chest radiographs or 10,000 chest radiographs. And then you can see, oh, it's going too high or too low, etc.
Thank you so much.
So Sam, correct me if I'm wrong. You mean that the DI value is already in the DICOM tag, so you can pick that on the screen when you have your
Yes.
PAC team
Yep.
display that particular value, right?
The EI and DI value should be listed in the DICOM header. So if you don't see it on your screen because of your hanging protocol, you should be able to request. Now, there is the small chance you might be using a really, really old piece of equipment, in which case that system does not calculate DI. But all modern, and I would say modern in the last 10 years, radiograph X-ray systems will have DI and EI in the header.
Thank you.
Yeah. So 0 is a good number, but we have like a range. If it's like acceptable on the image quality, you might be okay. But if it's like a far beyond, maybe like a 5 or 10, that is something that we need to concern. To like a
So we looked at it. We did a study and we looked at 100,000 plus studies. And we took those images and we looked at radiologists across the US and we asked them what is good and what is bad. And we found all the way out to plus or minus 8 or 10, they didn't really tell the difference. So the recommendation we make is, first and foremost, what you need to do is take a plot of your data over, say, a couple of months, and you, the radiologist, need to make sure you're comfortable with whatever. A good starting place would be 1 or 2 standard deviations of your data spread. That may be plus or minus 6 for you, and for me in my hospital it might be plus or minus 8. And so you just look at that spread and then take 1 or 2 standard deviations, and you should be safe within that range.
Yeah, thank you so much. So the next question from Dr. Anthony, this is the question from Dr. Jamari. So if we use the CR plate for the mammogram, instead of changing to the real digital mammography to reduce cost, any recommendation on this practice?
To clarify, I have seen small hospital that they already have the mammogram, right? But then when we change to digital era, suddenly they say, okay, full-field digital mammogram equipment is expensive. So they start using the CR plate for the mammogram. Is there anything that they need to kind of precaution on using?
Yeah, but ideally in the present day practice, there is a clear-cut shift to 3D mammogram. So much so people are even using now contrast mammography on a regular basis. But having said that, there is a definite cost factor which is involved, and all hospitals may not be able to afford this cost. But at the same time, I think CR is a good improvement over the film screen mammography which we had. Combined with ultrasound, I think this would be a fairly good answer or solution to most of the problems, because what we may not detect on radiographs could be compensated with our ultrasound study, which is done complementary to this. So I think with both of them together, but again, what we have been seeing on film screen mammography, like our microcal and other things, can be fairly well or even better seen on CR. We also should know that CR also can have post-processing just like DR, but not to the extent of DR, but still post-processing is possible, where we can enhance these densities and look at them clearly, and we can zoom them out and see how these calcifications are, especially when we are looking at microcalcification. Same thing with our interventional techniques also. We can place, ultrasound guided, we can place markers for taking biopsies or for surgery and so on. So all these things are also possible with CR. But ideal situation in the present day practice definitely is DR, because the sort of clarity and the depth of resolution which we get on DR and the sort of processing which is possible may not be possible on CR. But the trade-off is combining CR with an ultrasound, so as to have a trade-off and a balance between what we are losing and what we are gaining.
Yes, but one more question. I don't know whether this will go to the next session in mammogram or not, but for the CR, for mammogram using CR, usually mammogram we QC with the phantom, right? Do you think the phantom for the 3D full-field digital mammogram and the phantom for the mammogram that use CR plate should be different?
I think it should be different.
Because the specification of Phantom, I'm not sure that I have seen it. If they say this can be used with the CR, it's only for the 3D full field digital mammogram.
I think it should be different. Professor Sam, what do you say?
So with the CR versus DR
Yeah.
in mammography, was that the question?
Yeah,
The answer is
the QC for the Phantom, because usually when we request for the Phantom or we buy the Phantom, I'm not sure that it's for CR mammogram or for 3D full field digital mammogram. Should it be different
the QC is going to be the same in the sense that you use the same Phantom, but the outcome will be different. And so your tolerance for being able to say this is a good image will be different for CR versus DR. CR is just, as Dr. Anthony mentioned, it's just a little less sensitive. And so you need a little bit more radiation to get the same quality, so you can see the same calcifications and all of that. And so when it comes down to it, transitioning is expensive, but long-term, the cost will be recovered in the sense that you'll be using lower dose for our patients, and DR tends to last longer. CR plates do burn out quicker, and at least here in the West, they've stopped manufacturing CR plates for us. And so when they break, they're gone. We just have to throw them away. We have no way to replace them. And so we're being forced to go to the DR.
Thank you. So the next question is for Sam. So do pixel pitch or bit depth have any bit depth have anything to do with the technique, such as like a MA, KV, EIDI for each CR and DR imaging?
Yeah, that's a great question. So now you're getting into the technical parameters of the detector itself. So pixel pitch is just the distance, is a measurement of the distance of the detector elements. So a large pixel pitch means a big element. That means your resolution will be poor. Now, you also think of it as a bucket. If you have a big bucket, you can collect lots of radiation, so you don't need a lot. Small pixel pitch is a small bucket, so you need a lot more radiation to fill that same small bucket. And so a very small pixel pitch means you do usually have to adjust your MA. And so you usually have a little bit higher MA than a large pixel pitch. But the trade-off to that, as we've mentioned, is resolution. And so you almost always will have the system with the best pixel pitch so you can see the smallest structures. And then we just modify the dose a little bit on the back end. Now, that's usually something that once you've bought the system, that change, there's no more change. You don't change pixel pitch. That's built into the detector. So once you know that, you just set your technique from there, and you'll never have to think about it again.
Thank you. So it's bring me to the next question, Dr. Supakun, because I'm in the early days of the setting all this digital imaging and have seen that there's a certain kind of a discrepancy between the display monitors and also the detector. And someone tried to sell me a very high-end detector, but they have a lower-end monitors, and it doesn't match together. So how you recommend the hospital to link the result from our high level DR CR into the display monitor, because many hospitals try to lower the cost, and our medical grade monitors that the vendors claim is very, very high cost, and have seen a few hospitals that use regular off-the-shelf computer monitors and use it to display the our radiology image. Any comment on that? Because medical grade is so expensive.
It is, but medical grade makes a big difference in two areas: X-ray, so DRCR, and mammo. You can use just your normal monitor like I'm using right now for CT, MR, and even ultrasound. And that's because and nuclear medicine, because the resolution of those systems is actually much smaller. But Dr. Anthony mentioned that X-ray imaging and mammography is the highest resolution system that we have in radiology. And therefore, if you do have a a lower quality monitor, you will not see the quality that you just acquired in X-ray. So that is the trade-off. At the minimum, if you can have at least a couple of PAC stations that have the high quality, and those are ones that you use for your digital or planar radiography, portables, and mammo, then you're good.
Yeah. But at least in mammography, I think if possible, one should go for the highest megapixel possible, something like 12 or more. Because routine CT and MR and all, we view it at say 3 or 5 megapixels. But mammo, I think everybody recommends something about 12 or even more, because that really makes a difference. Yes.
Thank you.
So any questions from the audience on the chat box? Let me see. Still nothing. So I have the last questions on the collimation, because you mentioned a lot about the collimations and position, right? Patient position. I think that is maybe like the key things, not only on the radiograph and also the CT, because that is the key things to reduce the radiation dose and give the better image quality. So for me, when I read the study, how can I know if like my technologist do like the big screen and then like collimating like a very small for me to say, like trying to please me that, okay, we do the right correlation, but actually it's maybe like the big screen and
No,
just like
crop the image
crop. Yes. How can I know? Yeah.
to satisfy you.
That's a
Right.
trick. It's actually tricky. So obviously, if you have a very large area field of view, you're going to have more scatter in the image. So the tissue contrast will probably suffer a little bit. But the problem with these digital detectors and the post-processing is you can adjust that quite a bit. In fact, you can window and level usually using your mouse to overcome those problems. So the answer is it's actually really hard to tell the difference. But in extreme cases where they don't at all collimate, you will probably see a tissue contrast reduction.
Mm, yeah.
So
So
Dr. Subakun, for my experience, the DR is difficult, but CR usually if you see it enough, you know that your plate has a particular shape of the edge. So if they crop it, you know it.
okay. But I cannot use the DI and EI to tell if they crop it or not, right? Can I use that? No.
No, those values are specific to the anatomy of interest. So if you're doing like I showed you, the C-spine, it's only looking at the dose in the neck. So even if the area included shoulders and all the way up to the top of the head, it wouldn't know because it's only looking at the neck for the calculation of DI.
I see. Okay. Okay. Thank you so much. So Dr. Anthony, last question for you. So for the shielding, so what is like the current practice that you are doing right now? Are you still doing like the shielding when you take the radiograph, or any like suggestion? Is it like difficult to convince the patient or like to change the practice on that part? Because I think it's somehow challenging, because like the information that the patient or the population get about radiations, and even sometimes like for us, when when our technologists go to like take the portable radiograph to the patient, then at the nurse station, the nurse or like which, okay, let's hide behind that one or this one, so it's just like we scare. So what is like the workflow, or like how do you convince people?
Yeah, in our hospital we have both CR and DR. In fact, now CR is like a standby in case DR has any problem, because a lot of patients will have to be imaged. So CR is like a standby and used in emergencies where there is a breakdown for DR, if at all. And as far as portable is concerned, earlier it was CR. Now we are gradually changing over to DR for our portables also, because once you start giving this crisp, high quality images to the clinicians, then they will not go back. They will say, okay, we require this. There is some drop in resolution because we have used a CR cassette. So then we are forced to go back again and give DR to every department possible. So once DR is put in, then there is no going back, because people know the difference. Clinicians say there is some problem with your exposure without realizing, we have done it on CR. So that sort of thing has happened. So now it's always, if possible, always it's DR, because nothing, especially in a portable setting also, because Portable, of course, your positioning is not ideal. Patient is not in a cooperative manner. So a lot of things can go wrong. But all those, wrong things going wrong can be corrected to a certain extent and have a reasonably good radiograph if you're doing it on a portable DR rather than a portable CR. So that way, I think going ahead, it will be DR only. There is no doubt about it, because it's only a question of it's a matter of time when people get used to that sort of image quality. And for the patients also, though the cost is high, as Sam said, the radiation dose is low, and it is the advantages are much more because you're getting better radiographs, though the cost is high.
Okay. Okay. That's good.
Yes,
Yeah.
Dr. Subakun, I agree on your question. It's very difficult, especially when Sam showed the secondary chill and how the scatter is very low during this, modern technology, right? Even our own field radiologists, they're still skeptical on not using the secondary chill when we try to implement in kids or in women. So even our technologists and radiologists will say, why don't we use the chill, right? That's the concern, not the patients themselves, but also our radiology, even other doctors in related to radiology.
Yeah. So I feel like the collimation is more like the secondary shielding. You get like the right collimation. It's like the secondary shielding. So which means like the position, back to the basic position, center the patient and collimation. Yeah. Right. Yeah. Okay, sounds good. Thank you so much, both of you, for like a very informative session, simplify things and like a more practical. And at least I know right now that I need to look for the DICOM folder, look for the DI and EI, and I can give the comment to my technologists. And I hope the audience know right now how to look on those things and give the feedback instead of just telling, oh, it's a bad image quality, but I don't know how can I help you fix it. At least we know some parameter and can tell them what to do. So thank you so much, both of you. And for the audience, you can give us a feedback by click on the link, give us a feedback what we can do better or what topic that you want to hear from us. And for the next session, so since this is the monthly webinar series on the radiation enhancing optimization, here, let me share my screen. Yes. So the next session is on October 4th this year that we are going to talk about the mammogram on the image quality and those, and we're going to have more discussion on the CR and DR and how to the optimization on those things. And then the last session that we are going to talk about after we learned about like each modality, CT, IR, fluoroscopy, mammo, CR, and DR, we're going to have more like the wrap up session. Since we know this is like the team-based approach strategy to get the optimization to the patient. So we're gonna have the last session on the November 1st, 2025 that combine between like a medical physicist, technologist, and also radiologist that going to talk together and how we can make this thing happen. So please stay tuned on this lecture series, and thank you so much everyone, and I will see you again next month.
Thank you.
you.
Thank
Thank
you all.
you.
Thank you all. Bye. Bye.
Thank you, ma'am. With your permission, may I close the session now?
Yes, please. Thank you. Okay, thank you so much, Sam.